What's up? All right, happy Friday. Hope everybody's doing well. Hope everybody's had a good week. Wave back at you. Welcome to our Friday Q&A, fitness and performance, and all the other good stuff that you guys care about and want to know more about. So we're on YouTube and we're rocking and rolling on Instagram as always. So again, as we get into this, feel free to ask whatever you want from assessment. I know we talk a lot about the overhead squat and some various signs, but also progressions and programs and how to focus on fitness and performance goals. And certainly happy to answer some of those questions or maybe even clear up some of the cobwebs that you may have regarding training and coaching and all of that fun stuff. So welcome in. For my Instagrammers, fill out that comment, send it in, and I'll answer it. For my YouTubers, same thing. There's that comment section and or that chat section, and we can get started. So somebody lead me off with a good question. I didn't, again, this week. I was actually just in New York teaching this past weekend and didn't have any good emails that came through asking more for something. The only couple emails that I did get from people were, what to address when and where and why. So I'll kind of lead off with that. So when we start looking at dysfunction and we start looking at somebody doing that overhead squat, there's a few things that we really want to focus on first, right? So when you look at somebody, with clients and patients, I'm sure there's a lot of dysfunctions, whether it's lower extremity, lumbopelvic, hip, or upper body. Somebody may have all three of those, or cervical or sacroiliac joint dysfunction. So somebody may have everything, but we have a little bit of a hierarchy of what to address first and where to start. I know sometimes it can be like, well, they got this, they have upper body, they have lower extremity, they have lumbopelvic hip. Like there's just so much that I need to do with them. Where do I start? So number one, we start with the obstructive dysfunction. That's kind of our hierarchy here that we're going to kind of talk about. So start with their obstructive dysfunction first. That's kind of the reason why they came to you. So if they came to you with some shoulder discomfort or some back pain or some ankle or lower leg pain or discomforts, that's where I'm going to start. And I'm not going to treat the pain. I'm not going to go, oh, your knee hurts, so I'm going to focus on your knee. I'm going to say, okay, you got a little bit of shoulder something going on. Great. I do my overhead squat, identify there's upper body dysfunction, and I'm going to treat the signs or treat the dysfunction, not the diagnosis. I know I say that a lot, but that's going to be kind of the first step. Go obstructive. If there's no obstructive, you've been working with this client or patient of yours for a while and they feel pretty good other than the normal, like, sore from upper body day or sore from lower body day, easy enough. That will take that out of the equation. If there's nothing kind of obstructing them from, their daily movement and their routine and, everything's pretty good, focus on any asymmetries. And I know we get this conversation of, nobody's symmetrical, right? Okay, fine. But when there's significant asymmetries in regards to movement, that becomes an issue. When one arm doesn't have the same range of motion as the other, that becomes an issue. When one ankle doesn't have as much dorsiflexion as the other, that becomes an issue, right? So those are the things that we address first. And again, it could be something at lower leg, it could be something in upper body, it could be something in lumbopelvic hip. And with a lot of the asymmetries, it would probably benefit you on getting out or getting familiar with goniometry and really seeing what side is restricted, right? And that makes your intervention a little bit easier. Your intervention really is only one-sided at that point. So that would be the first step. So like I said, obstructive first, asymmetry second. If there are no asymmetries, then you're going to focus on the most dysfunctional segment. So that most dysfunctional segment is going to be the one that has kind of the glaring signs, the segment that has the most signs. So for example, if I had feet that kind of turned out a little bit, but I had arms full, scapula elevate, head go forward, that upper body dysfunction is the one I would focus on because most of the signs were coming from there, right? And if there is no most dysfunctional segment, start from the ground and work your way up. So start from lower extremity and work your way up. Dysfunction tracks faster from the ground up than from top down. So hopefully that kind of gets you thinking, gets you started. I can expand on that more if you guys would like, but I do have some questions here. Anne, I'm going to start with you, and then Patrick, I'll jump to you on YouTube. So, and with reference to corrective exercise, would the integration exercises be part of the warm up or resistance training? Great question. So the integration exercises would actually be part of that corrective warm up. So, how that kind of template exists now is release, mobilize, lengthen, right? That's the mobility or the release and overactive muscles, stretching whatever you need to stretch, improving joint space and whatever you need to improve. So that's the mobility side. And then the activation would be your isolated activation where you're just increasing neural drive to an underactive muscle. You have your core integration, which is more of like TVA something. So that TVA something could be a quadruped of some sort, whatever, hip bridge or something like that. Um, from your core integration, you then go into the stability integration side of things, and that's a single leg touchdown pattern or single leg excursion or your ITY progressions. Reactive activations would come next. That's where you're training that tissue or that muscle to decelerate. And then your subsystem integration would just kind of be pulling it all together, right? And then that would be that warm up, that corrective exercise warm up side that would take maybe 10, 15 minutes or so. And act as that person's warm up. So those integrative movements are part of that warm up. And then once you've done a circuit of that, or one round or two rounds, or whatever you have time for there, once you've done that, you then go into the regularly scheduled weight training, resistance training program of whatever it is that you want to do. And again, those exercises may look somewhat similar or be a completely different exercises there. So hopefully that's helpful. But like I said, to answer your question specifically, yes, those integrated exercise patterns of quadrupeds and hip bridges and chops and squat and rows and step up and your anterior oblique subsystem movements like step up and presses, those would all be part of that integrated corrective exercise routine. So good question. And Patrick, what are my thoughts or opinions on weight belts? Well, I have two, right? So for the general population, looking at just kind of training for everyday health and function, I don't use them, right? And here's one of the reasons why. Number one, I don't start with somebody in a max strength phase, right? So we have these progressions or this periodized program where we start with stability, where we're training that core musculature and control of those joints and control of that muscle tissue. So we're developing some of that kind of core stability. From there, we'll progress to that hypertrophy side where we start to increase the load, but there's still a stability or control component to it, right? Our tempos are a 202 tempo in that hypertrophy phase. So there's still control that person has to do. From there, we go into our max strength side. And now with that max strength side, I tend not to do one rep maxes with most of the kind of average person or average population. I tend to do somewhere in like the 3 to 5 range. I think that's a little bit more kind of quote unquote like realistic and functional. But I would kind of stay away from the weight belts because I'm not trying to have them rely on a crutch of that weight belt to stabilize their torso. Now, on the flip side of that coin, again, I don't know the population that you work with, but if you are working with those max strength based athletes who are really trying to PR every single time, who are putting significant load on their backs or in their hands or pressing overhead, whatever it is that they're doing, then maybe a weight belt is not being used as a crutch, but being used as a little bit of a supportive mechanism just to like minimize risk of injury. And that might be okay. So Like I said, for the most part, I don't use them, but there are some times um, it's certainly useful sometimes, right? So if you, like I said, if you are working with a competitive athlete, yeah, throw the weight belt on so they can get a competitive max strength athlete or power lifter or something like that. Then yeah, throw the weight belt on so they can hit that PR during competition or right prior to competition. That gets them that PR. But there are inherent risks with that, but that's okay. So hopefully that's helpful. Hopefully that kind of answers. I'm sure you're thinking along the same lines, right? We have agreed on a lot of stuff in here, Patrick. So, um, but that's kind of my opinion. If dysfunction comes before pain of the opposite or together, I don't exactly know what you mean there. Dysfunction can come before pain. It can come, we don't use pain as a metric, right? So don't use pain as a way to um, uh, you know, focus your intervention on, because pain can be from a whole lot of things. Um, you know, I tend not to. I internalize their conversation with me. So if they do say they have pain here, there, whatever, I understand that. I internalize it. It's great information to have, but we still have to go through that assessment side of things and figure out what's really going on. So I try not to use pain. What's the most effective way to deal with severe neck muscle spasms? Go see somebody. I can't give you advice on here because obviously I can't do an assessment. Don't know you. I don't know what your history is. So I can't say, hey, go do this thing because maybe that thing is not the correct thing to do. So I can't tell you an intervention when I have no idea, what's going on. So I would suggest go see somebody who's a qualified professional and see what they come up with. So, I like I said, I don't want to give too much info there because I don't want you to do the wrong thing. What's the best exercise to increase hip mobility for a client? So, BTF personal training number one, we got to make sure we do that assessment. We've identified there's a restriction in hip mobility, which there very well may be. It's very common. Somebody who's got an anterior pelvic tilt would have a reduction in that hip mobility side of things. Somebody who's got maybe excessive forward lean coming from lumbopelvic hip, basically anybody with lumbopelvic hip complex dysfunction may have some hip mobility issues. And oddly enough, the best way to improve that, I would say, three things: release the overactive muscles, right? That's going to help kind of turn down some of those muscles that might be kind of holding on or restricting that. Number two, I would certainly check out the self-administered joint mobilizations that are on the website. That use a band, use a strap, use whatever you have, and that's going to be I think incredibly helpful for that person. There's a couple different ways that you can do it, both of which are shown on the videos, but that really tends to have a dramatic improvement in hip mobility or hip range. Number three, you can do some stretches, kind of that hip complex or hip flexor complex stretch would be another piece there that you can add. And then since you're already doing those three things, you might as well throw in some glute stuff and set yourself up for success long term. So hopefully BTF personal training that's helpful for you. Release the overactive stuff, commonly rec fem, TFL, potentially anterior adductors, right? Do that hip mobilization, that self-administered hip mobilization with the band. That's going to improve some of that joint space. Hit some the kneeling hip flexor stretch, right? You can turn your foot in a little bit to hit TFL a little bit more, and then do some glute stuff, and then reassess. And I think you're going to find a little bit better mobility for that person. You're going to see that their squat looks a little bit better. They can get down into that squat a little bit better with a little less restriction there, and kind of go from there. Adonis, what's happening? Happy Friday. Good to see you on again. Asymmetrical weight shift. Let's talk about that. Um, yeah. So what you focus on with that asymmetrical weight shift. So again, when we look at an asymmetrical weight shift, let's say an asymmetrical weight shift off to the right. So when you're looking at that client or patient from the posterior view, they drop down into the squat and their hips kind of shift off to that right side. Well, what we're looking at is that left leg is going into that knee bow out, basically. And I'm going to assume that this asymmetrical weight shift is coming from lumbo-pelvic hip, right? So we have to do that regular overhead squat. We see that hip shift to the right. And then when we elevate the heels and put the hands on the hips, they're still shifting to the right, right? So that asymmetrical weight shift can come from different segments, but I'm going to assume it's lumbo-pelvic hip complex in this conversation that we're having right here. So I've done that. They still have that shift with modification. So I know it's coming from lumbo-pelvic hip. And my left, since I'm shifting to my right, my left leg is going to be the one that is going into this knee bow out. So I'm creating external rotation there at the femur. So my piriformis, my posterior fibers of adductor magnus, and my bicep fem are going to be overactive on that left side. So I'm going to release that left side, piriformis, posterior fibers, adductor magnus, and bicep fem. And then I can do a joint mobilization of, let's say, do those open books. So I can do kind of like a lumbar SI mobilization there. And then what I'll focus on is maybe the Captain Morgan stretch on that left side only. And then I'll do activations on my right glute. So I'll do glute max, glute med, right side glute activation only, run through kind of that activation sequence or circuit for that right side. And then I'll reassess and see if I made any change. Now that's kind of what I'm going to be focused on. I'm not really going to do much of anything else. It's pretty simple. It's a simple, quick, easy fix for that asymmetrical weight shift. So that's kind of what I'm focused on. Now, what we may find is that as you improve somebody's asymmetrical weight shift, the next dysfunction that you find is bilateral knee bow in, right? Which is an okay sign because it just gives me something else to focus on and going, okay, well, I've reduced or I've eliminated that asymmetrical weight shift. Now we have knee bow in, so let's focus on maybe some glute max activation on both sides, right? And maybe that clears it up a little bit. So that's one that's an okay sign to when you do a corrective kind of intervention for the asymmetrical weight shift, you may find a different sign pop up. That's good. That's how you know you're on the right track, right? So hopefully that's kind of helpful. And again, I know that asymmetrical weight shift can be kind of daunting. It can kind of be a little bit of a oh my gosh, what do I do kind of thing. But if you treat it as knee bow out on the side opposite the shift and glute activation on the side of the shift, I think you're going to have some pretty good success. Right? Hopefully that works. Let's see, what else do I have in here? Good questions. Appreciate all that. Single leg squat assessment, the trunk and hip rotates out. What could be weak or over? That's a tough one, right? So I know we're taught, kind of classically taught, the single leg squat assessment. That's a tough assessment to do. I tend to stay away from that because really on single leg, you're going to have compensations somewhere, right? It's going to happen. You're going to start to shift and rotate to try and kind of keep or maintain that center of balance. So I tend to stay away from the single leg squat assessment and focus primarily on my, two leg regular overhead squat assessment. If you're working with somebody who's a little bit higher level athlete, or somebody who's done the overhead squat assessment and kind of knows their dysfunctions and they can kind of like fix it or correct it on their own, just kind of like knowing what they're going to fall into or what their dysfunction are, they're going to compensate by correcting it somehow. What I've done two things. Number one, I have people close their eyes, right? That takes away some of that proprioception, right? So you might see some things pop up that you normally wouldn't. The other one that I've done, especially with the athlete side of things, is had them do like a little mini depth jump or like a drop down. And that depth jump, now you've increased the speed at which that assessment is really happening there. Shows up, things start to show up, right? So I'm not talking about a huge box they're going to step down. It's just like a little I don't know, 12-inch box that they can step down, land on both legs into that squat. They're not jumping, they're just landing, and you'll start to see some things pop up. Feet turn out, knees bow in, anterior pelvic tilt. So I would stick to that versus the single leg squat assessment. There's not many people that can do a phenomenal single leg squat in the first place, right? There's very few people that can do a pistol squat with great form. So I kind of leave that one alone. Right? Hopefully that helps and maybe makes it easier for you assessment wise. Where to find the benefits of using the different tempos, or what are the benefits of, where to find the benefits? They are on the courses. So we have a an acute variable course on the website that kind of goes into some of that. We're also going to be publishing soon a couple new courses with interset rest intervals and talking a little bit more about some tempos and things like that. So those courses are coming, but the acute variables course that we have now talks about the benefits of those tempos and why stability endurance has a 3-2-1 tempo. So 3-second eccentric, 2-second isometric hold, 1-second concentric. Your hypertrophy training is a 2-0-2 tempo. And then obviously max strength and power doesn't really have tempo, but power tempo is as explosive as possible. That should make sense. But there is some info on there for you in those courses. Speaking of courses, Arish from YouTube, any courses on any online courses you recommend? Yeah, all of them. No, I would say depending on what your scope of practice is, I don't know what you do, but if you're a personal trainer, the CPT kind of track on the Brookbush Institute website, that CPT track has most of the courses that, or really all of the courses, are pretty applicable and kind of relatable to the profession that you do. Same with the HMS. So the HMS kind of bridges the gap between kind of personal training and kind of a little bit of the PT manual therapy side. So there are some additional courses and assessment courses in there. If you are a physiotherapist or a manual therapist, the IMT track, so the integrated manual therapist track on the website, has some good courses for you there as well. Some manual therapy courses that are in that track, which are really going to be really applicable to you doing the work that you do with your patient base. So I would say instead of just hopping online and going and being bombarded by all the courses that are on the website, pick one of those tracks depending on what you want to kind of improve in or what you want to get better at, and kind of go from there, right? Because there's hundreds of courses on the website, you get lost there, right? So picking a track can kind of keep you, and we have recommended course orders. So picking that track and going through that course order might make it a little bit easier of a task for you to kind of go and figure out and find what you want. Good question. Great question. Thank you for that. How can you defer scoliosis from musculoskeletal? So do your assessment, right? And this kind of goes across the board. It doesn't have to just be scoliosis. It can be any of those. If you're questioning, and I actually just did a webinar on Wednesday with our members about feet turn out, and people go, oh, it's my hips. That's why my feet have to be turned out. They're shaped differently. They're anteverted, retro, whatever. Any of those structural kind of abnormalities that people think or talk about, here's what we do. You do your assessment. You mark down the signs. I'm going to use scoliosis since that's what you asked for. Typically, somebody who's got scoliosis will have an asymmetrical weight shift. Right? Okay, great. So let's look at that asymmetrical weight shift, break down the sign, kind of do exactly what I just said, release the overactive stuff on the side opposite the shift, activate the muscles that are on the side of the shift, like glutes, and then reassess. And in your reassessment, you notice that shift gets better, then you know it's not structural. You know it's muscular, right? If you do all of that a few times, right, and it's still the same, right, you can film it, you can have them film whatever you feel comfortable with. Take a look at it, right? Did it get any better? If it's not getting better, there's a couple things you can do. Number one, go back to the drawing board. Maybe you're seeing something that's not actually there, or maybe you're trying to address something that doesn't need to be addressed. Number two, maybe refer to somebody else, refer out and see, yeah, maybe they need some imaging, maybe they need different assessment, maybe they need something that may be outside your scope, right? So check that out. Maybe that's a potential thing that they need. But like I said, if they're not getting better and you've done all that, you've checked all your boxes and you've gone through it, then yeah, hey, you know what? Maybe it is structural. Maybe you're, whatever, you have scoliosis. And there's nothing you can do about it. You can't change it. So what you do instead is you still treat it as the sign of dysfunction. You still treat it, their warm up still going to consist of releasing the overactive muscles on the side opposite the shift, activating the muscles on the side of the shift, run through like that little mini circuit or that corrective exercise warm up, and then go into their regularly scheduled training program, whatever it may be, right? And what you're going to find is they're going to feel better and kind of move better and maybe get better recruitment of those the primary muscles of glutes and core and all that fun stuff. And you're not going to fix it, but they'll feel better or they'll be out of being less discomfort or less pain, particularly after they get done working out, which is part of the goal, right? Our goal as health and wellness professionals is to make people feel better, right? Obviously, improve performance and all of that, but train out of that, train out of dysfunction and get them moving more appropriately. So that's kind of where I would go with that. Like I talked about on Wednesday with the foot turnout thing, most people's hips are not significantly shaped differently enough that would require them to take a different stance, right? You're just kind of falling back on some of the dysfunctions, but you do what you can, right? And you assess, do your intervention, and most importantly, reassess. Right? Cool. Hopefully that's helpful. Let's see what else I got. Great questions, guys. This has been phenomenal. Good job. Hopefully I've answered most of that. Training Vic to be fit, training scoliosis and full spinal fusions. You do your assessment, you treat the dysfunction, right? You make them move better during that initial kind of corrective exercise warm up, and then just go and do what they can, right? There's nothing you should kind of say, oh, you have this specific thing, scoliosis or fusion or whatever. Let's not do anything with you, right? I'm not going to treat them as such. I'm not going to say, nope, you can't do anything with you, right? I'm going to do that warm up, release, mobilize, lengthen, activate, integrate. I'm going to do that warm up and then get them into a programmed or periodized exercise routine. Right? And treat the dysfunction, not the diagnosis. Treat the dysfunction, not the diagnosis. Can't say that enough. All right. Let's see. Got a bunch of people jumping on, waving back at you. Any tips on how to keep muscles from getting overactive in an elderly population? Keep Adam on that home exercise program of giving them a couple releases. Again, with the elderly population, a lot of time is spent, not always, but kind of generalized here, a lot of time is spent kind of sitting and not as mobile as the younger population. Again, generalized, but so if you can get them up and doing some of these techniques just a couple times throughout the day, that may help long term. Getting up and moving is certainly important, but one of the things that I've done for home exercise programs is say, here's a ball, here's a band, spend 30 seconds doing a release of your gasstrut, for instance, in between commercials of, whatever it is you're watching, right? The other thing I've done is I've had some clients, people that I've known buy the massage guns, the hypervolts. So these percussion instruments, they're easy. People buy them on their own. There's all kinds of knockoffs and stuff that they can get, but I like the Hypervolt or the Hyper Ice based products. They can buy them and they can do that while they're sitting down doing whatever it is that they're doing. So it's a great investment. So if your client or patient can do that, that's phenomenal. I don't know if that was very, very helpful. There's no secret tips or tricks. Go from there. Ballet dancers and feet turnout. Ballet dancers, for the most part, are hypermobile. So, obviously, that is part of their stance, and they need to do that. And they've trained that way for so long. Um, I would definitely recommend doing that assessment if you do work with ballet dancers, or just dancers in general, um, gymnasts, yoga instructors, right? Those yogis, they tend to be hypermobile for the most part, not always, but tend to be hypermobile. So do your assessment, do your release techniques. They tend not to need to be stretched, right? So if you can get your foot over your head, you don't need more stretching. And then activations are going to be key for them. So make sure you're doing some controlled activations. Beautiful. I'm almost out of time here. I'm sorry. I'm going to scroll down. I know you had a lot of people jump on and ask questions, but um, Nebo out is related with posterior pelvic tilt. Certainly could be some relationship there, but really Nebo out, asymmetrical weight shift, they're associated with secret iliac joint dysfunction. That's kind of where you would want to kind of start. If you're a PT, if you're a personal trainer, or I should say, if you're a physio or physical therapist, if you're a personal trainer, just treat that Nebo out. Don't worry about posterior pelvic tilt. You don't see too much unless you're in geriatric, um, and it's kind of still glutes that need to be activated. CEUs for PTs, PTAs, everything's online. All the courses are accepted and accredited for that. Um, Questions. Let's see. Got maybe a minute to go, but I think I got everybody. So valgus, so knee bow in is always related with anterior pelvic tilt. You do see a lot of it go together, but not always. Again, if you see knee bow in, or if you see that valgus knee, make sure you're taking a look at the side view as well to see if you have that anterior pelvic tilt. There are some similar muscles. Adductors are hip flexors as well. Do that assessment and treat what you see, or do your interventions um, just on what you see. So, guys, that's my time. Thank you very much. Happy Friday. Go do great things. Have a good weekend. And I will see you guys next week, next Friday. As always, come with great questions. You guys were awesome. Go be awesome. See you guys soon.